Thank you so much, sir. Um, Amit, we can start the meeting, right?
Yes, doctor. We can.
Thank you so much.
It's
So, yeah, greetings to one and all. Greetings from Manipal Hospitals and Manipal Comprehensive Cancer Center. So, this is the third weekly webinar series of the Musculoskeletal Oncology Symposium, the 2020 edition. So, to start with, in this meeting, we'll be focusing on bone metastasis. So, our program is going to be like this. We'll have 4 speakers, including myself. Each talk will be for 15 minutes, and we'll be sharing our experiences, one from the medical oncology side about the advances in therapy, and Dr. Sanjeev Sharma, who's a radiation oncologist, who will be sharing about the role of radiotherapy. Where do we look, how are we looking at it, palliation or much more than palliation in scenarios of bone metastasis? Third, I'll be sharing my views on the surgical options for extremity bone metastasis. And Dr. Thomas, who's a consultant spine surgeon, he'll be sharing his views on the evaluation management of the spinal metastasis, which actually would form majority of the bulk of the bone metastasis in a practice in a sarcoma center. So just to start with, I'd like to invite Dr. Amit, who's a consultant medical oncologist, who's the head of the department. Sir, I'll just stop sharing my screen, and he'll be talking about the advances in medical oncology. Is there actually a shot in the arm for metastatic bone disease with the advances?
Thank you, Dr. Srimant.
Could you share your screen, sir? Yeah, perfect.
So good evening, everyone. So Dr. Srimant has given me a very interesting topic, a shot in the arm for metastatic bone disease, advances in medical oncology. Now, so there have been a lot of advances happening in medical oncology. We kind of believe oncology is the way medical oncology is changing. It is looking at how the biology of cancer is and trying to target it in different ways, and that's probably leading to the most advances which we are seeing in medical oncology. We have better diagnostic tools. Definitely, we've got. We get testing level to the level of molecular testing to try to find out about genomics of cancer. We have better supportive care for our patients. We no longer see patients vomiting and getting admitted with all the old related problems. Nowadays, we see newer issues, but supportive care has definitely changed. We have some new chemotherapy drugs, but again, if I talk to any patient, no one likes chemotherapy, but we do have better chemotherapy drugs which have better side effects. But what is better is the advances happening in terms of targeted therapies and biological therapies. And I would like to kind of say that this is the way cancer care is going to change, and we are going to understand more and more targets of why this cancer has developed and how this cancer is progressing. And once we understand these pathways, we target all these pathways with newer targeted drugs. And many of these targeted drugs are oral tablets which we use in cancer care. And we see some wonderful responses. We may not be curing our stage 4 patients, but we are definitely seeing wonderful responses, especially in metastatic bone metastasis. These are groups of patients who are really doing well. Now, there are also biological therapies where we are talking of using drugs like bevacizumab, which are biological drugs, or using monoclonal antibodies for their treatment. And now we have gone to personalized therapy. Cancer care has now become much more personalized. Each patient having the same cancer can be of different types. If, for example, lung cancer can be of 7-8 different types of lung cancers, and all of them will be treated differently. So we personalize our treatment according to that and then treat that cancer. And the latest advance and one of the most exciting ones has been immunotherapy. And immunotherapy is kind of changing the way we look at cancer. And I will tell you about it also. So I will kind of just, because I said immunotherapy first, I will just tell you, because this is the most recent advance in cancer care, and this is something which has excited all of us. I will just tell you what is immunotherapy. What we have understood now is, how does cancer grow and propagate? What we understand, cancer releases any cell which is being destroyed in the body. Cancer are our own body cells. They are not foreign cells. They are our own body cells which are multiplying uncontrolled. Now, normally our immune system, that is our T cells, would have identified that and killed them. And that's how a balance is created in our human body between the good and the bad. And what now is happening is, in cancer patients, the T cells are being suppressed, and that suppression is allowing the cancer cells to grow. So what we have found out is what is the pathway by which the T cells are suppressed, and this is now being done by what is known as PD-1, PD-L1 pathway. The cancer cells are increasing the PD-L1 expression, and that is causing the T cells to get suppressed, and the T cells are no longer active. So what they have found now are new drugs called immunotherapy or checkpoint inhibitor drugs. They block the PD-1, PD-L1 pathway, and they cause the T cells to become active again. And these T cells then go and kill the cancer cells. Why are we so impressed with immunotherapy? We know chemotherapy kills cells, but after some time, those cells grow back and they develop resistance, and patients again will relapse and progress in stage 4 disease. But immunotherapy, when the immune system becomes active, can actually kill cells and remain active for a long amount of time, even after stopping the immunotherapy, and it can give us wonderful long-term responses. Where is immunotherapy being used in cancer care now? It is amazing to see how in the last 3 years, almost every cancer has got included in the immunotherapy bucket. It started off with melanoma, kidney cancer, lung cancer, bladder cancers, head and neck cancers, liver cancers, lymphoma, stomach, cervix. I can keep going on and on. All these cancers are now being treated with immunotherapy, or immunotherapy is being used in either single agent or combination for many of these cancers. What happens when we see bone metastasis? Now, when we see bone metastasis, we always say, find the primary. It's no longer an era where you say, oh, it's bone metastasis, it's stage 4, this patient's not going to do well for a long time, let's not just palliate him. It's no longer that way. We always say, chase the primary and find the primary, which we do by doing a PET-CT scan, we do biopsies, we do IHCs. And with these IHC markers, we are able to identify what the primary is. The most common primaries we see is prostate cancer. We usually see lung cancer in males. We see breast cancer in females. We see renal cell cancer, colon cancer sometimes. But these are the cancers which we should chase when we see bone metastasis. Now, let me run you through cases and examples of how we do the chasing. Now, this is a patient who 74-year-old male who presented to us in April 2018. He had presented with bone pains and cough. Now, when he came with bone pains and cough, he was evaluated outside and he was found to have multiple bone metastasis. And we started chasing and looking for the primary. We ended up doing an X-ray and we found a lung mass. Once this is there, we always do a PET scan. And we did a PET scan and we found a big lung mass, pancreas tumor erosing into the ribs. We saw multiple lung metastasis. We saw multiple bone metastasis. And this was stage 4 lung cancer. Now, this is how his X-ray looked like if you look at the lung part. A massive left lung mass, completely causing pressure effects on the lung. And due to this, the patient was symptomatic with cough, and he also had multiple bone metastasis. Now, he's also 74, and if you can see carefully in that X-ray, you can also see those sutures of sternotomy sutures. So he's been operated for a cardiac issue. Now, there was a time when people would say 74, cardiac patient operated, very old, lung cancer, stage 4, please leave him alone. But this is where the time has changed, the era has changed. We did a lung biopsy. We found it to be a poorly differentiated lung cancer. We did a TTF1 IHC, TTF1 positive, P40 negative. We know this is adenocarcinoma lung. We have identified it. We then send out the molecular testing. We found EGFR negative, ALK negative. And we did a test in IHC called PDL1. And we found PDL1 is positive. Now for us, this is PDL1 lung cancer who can respond to immunotherapy, and that becomes our treatment of choice. But he had fracture of the right femur. Now he underwent surgery. There was closed reduction, internal fixation, and this was in April 2018. And we started him on immunotherapy immediately after his recovery. Within a week of May is when we gave him the first dose of immunotherapy. Now immunotherapy is nothing but IV infusion of the new drug. Nivolumab was what was used that time. And this is the findings you see after 8 doses of nivolumab, October 2018. You can see how the change is. This is what immunotherapy can do when it works well for patients. The left lung mass completely shrunk down, disappeared. Patient's quality of life dramatically improved. He started walking around. He got completely mobile. He became active, and he started again having a good normal life. We treated him continuously with immunotherapy for 16 doses, and we stopped in May 2018 and May 2019. And then we left him on observation. And even now, 1.5 years down the line, he's absolutely doing well. So this is the amazing thing about immunotherapy. It's a stage 4 patient. It has multiple bone mets. He has lung meds, he responds, and the response is sustaining even after stopping treatment. There was a time when the survival of these patients used to be 6 to 8 months. We used to say, if we get a year, we have done an amazing job. And now 2.5 years down the line, without treatment, he's doing very well. And this is what is very encouraging about this kind of treatment. Let me show you another patient. Here's a 52-year-old male who presented with a history of kidney cancer, which had been operated in June 2015. It was a clear cell kidney cancer. He came to us with severe back pain in December 2015. He was found to have a large retroperitoneal mass in the pelvic para-aortic region, and he also had multiple bone metastasis. Now, this patient, we used to say always treat them with sunitinib because that is an oral targeted drug. We gave it for 4 months, but he progressed. And this is how he progressed. There was increase in the disease in the para-aortic region. He had developed multiple bone metastases growing. He developed liver metastasis, and his general condition deteriorated dramatically. Now, this is the time we spoke to the family. There was not much options available. And we spoke that there is a new immunotherapy drug if they want to try. And they said, yes, they want to give it a shot. If you see the scan, after 3 doses of nivolumab, and you see a dramatic response. The mass has completely disappeared. Just in 3 doses, in 2 months, we saw the PET scan showing a dramatic improvement. His bone lesions resolved, all the uptake in the bone lesions disappeared, the liver lesions resolved, and patient's condition immediately improved. He received 1 year of nivolumab, and we eventually got tired of it. He kept saying, you're doing PET scans, everything is normal, let us stop. And we also agreed, let us stop. In June 2017, we stopped. And even now, this patient is in complete remission 4 years down the line, November 2020. Now, survival of patients in sunitinib failures in the previous era in RCC with bone metastasis used to be about 4 to 6 months. And now you see this patient 4 years down the line. There's a potential he may be cured. Another patient, 79 years, adenocarcinoma lung, mediastinal lymph nodes, multiple bone metastasis. He's negative for everything. PD-L1 was positive. This was how his angry tumor was looking like in the lung, and he had metastasis. Just 4 doses of immunotherapy, and that whole lung mass has disappeared. There's clear improvement. Again, his bone lesions improved. We gave him bone, we do give our patient bisphosphonates for when they have bone metastasis for bone remodeling. But apart from that, we did not give him any other treatment, no chemotherapy, no other agent of treatment. And then we stopped treatment. Even now, 1 year down the line, he's doing well. So this is how cancer care has changed. Now, in lung cancer, also another situation we see is where you have multiple bone metastases and you have female patients or young male patients, and we see they have adenocarcinoma, and we find the driver mutation, EGFR. We treat them with oral tablets, and again, they respond so dramatically. So this is why we always say, don't give up on your patients who have stage 4 disease. Last patient, 46-year-old female, she presented to the orthopedic with severe bone pains. They did an MRI. They found multiple bone metastases. They referred her to us. We did a PET scan. We found it was a breast primary with multiple bone metastases. We did a biopsy. We found ERPR positive, HER2 negative. Now, whenever we see ERPR HER2 positive with HER2 negative, we know these patients will respond well to oral hormonal tablets. But that is the time we also added the advanced CDK4/6 inhibitor called palbociclib to her treatment. So this was a new therapy. You combine it to hormonal therapy, you increase your responses, and you increase your duration of response. Within 3 months, she's PET negative. And she continued on this kind of a treatment. Again, very good response. For 3 years, she went on with this oral combination of tablets, just palbociclib and letrozole as a hormonal tablet. In breast cancer, again, we say the same thing. When you have breast cancer with multiple bone metastases, absolutely do not give up on your patients. They may do well even with just oral hormonal tablets if they are ERPR positive with the CDK4/6 inhibitors. But if they are ERPR negative and HER2 positive, again, the responses to targeted and biological therapies is very good. We use a combination there of chemotherapy with trastuzumab and pertuzumab. These are newer biological therapies. Or we use something called as antibody drug conjugates, which is a combination of chemo and a monoclonal antibody all in one. So you give the single drug and you see amazing responses. So what I would like to conclude with is, whenever we see patients with bone metastasis, never just go out and tell your patient, oh, this is stage 4 and you are for palliation. That's one thing we should never do. Yes, tell your patients you are stage 4 because that is the reality of their disease. But tell them in the present era, stage 4 disease doesn't mean a death sentence at all. You have a lot of advances taking place and you can integrate all your advances. And the integration not only comes from the medical oncology, but also from the radiation oncology, from the orthopedic, from the surgical oncology. And we integrate all these to improve the survival of patients. So I would like to conclude, give every patient a chance. There can be patients who will show dramatic responses. You will improve their quality of life. You will improve their duration of survival. And you may potentially be curing some of your patients, even though they are stage 4. So with this, I would like to thank Srimant for giving me this opportunity. Thank you very much, everyone.
Thank you so much, Dr. Amit. I just have one small question or a takeaway from your crisp presentation. So to put it simply, getting the diagnosis right is also important, right? In situations of patients coming with bone metastasis. As a surgeon, I'm putting it across. So it's not about I want to operate immediately. So trying to get the diagnosis at least in a day or two, doing the relevant test would definitely help take it forward.
Yes, so definitely, I agree with what you're saying. We should chase it and try to get a biopsy properly done, get the tissue, and do also a PET scan. So don't sometimes rush into trying to do a surgery first immediately without finding out what the primary is. So try to get a PET scan done, try to find your primary. Now, depending on your primary, then you can decide which side you want to biopsy. Sometimes you can biopsy a soft tissue, which will give you better tissue to do the IHC and the molecular markers. Sometimes in bone tissue, I cannot do all those kind of markers. So that's why we always say, do a PET scan, find the primary, get the right tissue, and then test it with IHC and the molecular markers, and then proceed for your treatment.
So even if it takes probably a day or two, I think we're looking at a good long-term outlook.
So yes. never be in an absolute hurry. If your patient is stable, never be in a hurry. It is not that a few days will make a change. So sometimes people start panicking, patients start worrying that no, few days will make a big change. It's not that. The reality is, if you find out what is driving the cancer, and with that information, you are going to treat better. And if you found the primary, you're definitely going to treat them in a better way than just treating them blindly.
Yeah, and so just to put it across, trying to be in a hurry is more commonly in pathological fractures. So still having a pathological fracture, doing a PET scan would definitely help us try to find out, as all the factors which you mentioned across. Thank you so much, Dr. Amit.
Right. Thank you.
Yeah. So next, I'd like to request Dr. Sanjeev to share his views on how radiotherapy is taken forward. Based on as a continuation for Dr. Amit's talk. Is it just palliation, or are we like really dealing with a lot more in radiotherapy?
Okay, my slides are visible?
Yes, sir.
All right.
Thank you.
So, good evening, everyone. Thank you, Dr. Srimant, for giving me this opportunity to speak on this topic. So the topic, friends, today will be radiotherapy in bone metastasis. Is it just palliation or much more? So I hope at the end of the talk, I'll be able to convince you that we have successfully moved radiation from achieving excellent palliation to also contributing towards survival and progression-free survival, and adding to what medical oncology achieves so nicely in these patients. So let's start with a case report. It's a known case of carcinoma breast. At some point of natural history, she develops gradually worsening low back pain secondary to a lesion in L4, completely bedridden. And that's the point when I see her, and I gave her single fraction 8 grade to the L4 vertebra in February 2019. She had complete pain relief in 2 weeks' time, became ambulatory again, and I spoke to her today morning. She continues to be free of pain as of today. So moving forward, there's another case report where radiation plays a completely different role. So here, there is a patient of carcinoma stomach who is diagnosed with only 2 bony metastases, what we call as an oligometastasis. Patient is put on systemic therapy. It has good local regional response, but there is a progression in the bony lesions. So we took the patient up for SBRT to these two lesions in the sacrum and left third rib lesions. 6 months down the line, patient comes with a pain in the left shoulder. There's a new lesion in the left shoulder, but the previous lesions have completely resolved. So we again considered the patient for SBRT to the left scapular lesion. And patient comes back in December 20 with complete pain relief in that area. But now there's a new lesion in the left seventh rib, which is causing pain. And today morning, we have started him on the SBRT to this area. So this is a new role for radiation, where those areas who don't respond to the systemic chemotherapy, radiation can take care of those so that the medical oncology can successfully focus on other parts of the disease. Now, before I go forward, I would like to take you, especially those gentlemen or those friends who are non-radiation oncologists, a few terms about radiation. So one is conventional two-dimensional radiation, which is the first one which we have done for ages from my student days, where you use X-rays to focus the radiation on, say, the L4 vertebra. Then we moved on to conventional three-dimensional, where we used CT scan. Now we could see where all radiation was going, which earlier we couldn't. We moved one step forward and made it three-dimensional conformal, where we tried to make effort to make sure radiation doesn't go to the other structures and covers only the target area. IMRT is one step forward, where it exactly takes the shape of the tumor. And the latest buzzword is the SPRT, but it's stereotactic body radiotherapy, which is a highly conformal form of radiation, where you can focus radiation on the whole of the vertebra or only the part of it. You can give very high doses, but at the same time, you can spare the spinal cord. So let's move to the first role, radiation for the role of symptomatic bone metastasis. It's the commonest indication for palliative radiation, and it achieves very good palliation for uncomplicated metastasis. That's very important to know. So this won't work for complicated metastasis. So which means no pathological fracture, no spinal cord compression. There is large body of level 1 evidence which shows that single fraction radiation is as effective as multi-fraction radiation. It's a quick treatment. Patient can be out of the department in about 2 hours time, and they get good pain relief in 2 to 4 weeks time. So a last systematic review in 2018, conclusively showed that there's no difference between the single fraction versus multi-fraction radiation, except for the retreatment rates, which in the single fraction arm tend to be higher. But a subsequent systematic review attributed this to reluctance on the part of the radiation oncologist to subject the patient to retreatment once they have been given higher doses. So which means it would be effective, and the same effectiveness of the single fraction versus multiple fraction, sustains in the retreatment setting also. So the take-home message, my friends, would be the standard of care for uncomplicated painful bony metastasis is 8 gray of single fraction radiation, and this forms a part of most of the guidelines and editorial commentaries, reviews, etc. So what are the potential limitations of it? The potential limitation is some people consider the pain relief to be suboptimal, and the dose 8 gray is definitely not enough to kill the tumor. So hence cannot be used for cord compression or where there's a need to achieve local control, as I showed you in my second case just now. You cannot escalate this dose because of the spinal cord tolerance. And again, to highlight, we need to make sure that spinal instability or pathological fracture is not the cause of the pain. This will not work there. So next step is spinal cord compression. Radiation remains the most common treatment for this situation. So it's a first-line therapy for radio-responsive tumors, and it can be used as post-operative radiotherapy after surgery or as a definitive radiation if surgery is not feasible. Again, there's level 1 evidence which suggests that shorter courses of radiation are as effective as longer courses. My personal favorite for a long time has been 20 gray in 5 fractions, and it gives good improvement. Again, retreatment in the same schedule remains equally effective. So next, coming to the main part of the talk, which is about stereotactic body radiotherapy. And so the indications, classical indications as of now are continuation of symptomatic bone metastasis to add local control to the pain relief, oligometastatic disease, in that situation to increase overall survival and progression-free survival. In the post-op situation, to reduce local recurrences, at the same time to make the surgery less invasive, and to avoid neurological complications whenever re-irradiation is required. We need to know it's a complex and resource-intensive treatment as compared to single fraction 8-degree conventional radiation, does carry a certain risk of a definite finite risk of radiation myelitis and vertebral compression fracture. It's very low, but it definitely remains. Patient selection is very important, but since subsequent talk is going to cover this, I think I'll skip that right now. But basically, it takes into account a combination of factors concerning neurological, oncological, mechanical, and systemic factors. And we always need to make sure that spinal instability is not contributing towards the pain. In that situation, radiation would be ineffective. Now let's look at the first indication of SBRT, which is for pain relief. So RTOG 0631 was a randomized trial which compared single fraction of SBRT to single fraction of conventional external radiation and failed to show any improvement in pain relief with SBRT. A subsequent randomized trial in Canada took up slightly different schedule of SBRT and compare it with 20 grain 5 fraction, slightly longer schedule. And this particular trial showed that the SBRT, the pain relief at 3 and 6 months was, significantly more, almost double than what you can achieve with conventional radiation. So a systematic review subsequently looked into this topic and concluded that pain relief which you can achieve with SBRT is almost double of what you can achieve with conventional radiation. At the same time, you can achieve very high local control rates and about 10% risk of vertebral compression fracture would be there. Now, the present data, the vertebral compression fracture risk is quite low because we have understood now as to what are the factors which lead to the vertebral compression fracture, and we avoid that. So next comes the current most important indication for SBRT, which is in the setting of oligometastatic disease. This is one area where SBRT is, coming forward in a big way. Lots of level 1 evidence is being generated. So the Saber Comet trial was the first one, which for oligometastatic disease. By oligometastatic, we mean metastasis to less than 5 sites. And here, in addition to standard of care, the patients were randomized to SBRT or no SBRT, with the primary endpoint being overall survival. And for the first time in this particular trial, SBRT was found to add significantly to the survival, of course, at the expense of some toxicity, which this was the first trial. So that time SBRT toxicity was found to be higher. A subsequent trial published this year tried to look at a slightly different endpoint for oligometastatic recurrent prostate patients. And the primary endpoint, what it tried to look at was, can we delay the androgen deprivation therapy because of the quality of life issues? And again, this trial showed that, yes, with the addition of SBRT, in a significant number of patients, the androgen deprivation therapy can be postponed. Another trial tried to look at whether can SBRT improve 6 months progression-free survival, and again the results were positive. And as the trials have progressed, the toxicity rates continue to go on decrease. So subsequently a review looked at this particular topic, and so it has concluded that with the addition of SBRT in the oligometastatic setting, you can achieve close to 95% local controls and very, very acceptable acute as well as the late toxicity rates. So moving forward from oligometastatic disease, is the next indication is in the post-op setting. Now, in the post-op setting, we have used conventional radiation for a long time with poor local control rates. SBRT, once it has come, it has tremendously increased the long-term durable local control rates with acceptable morbidity. More important, it allows surgery to be minimally invasive with less morbidity. So, but SBRT in the post-op setting is challenging because of these artifacts produced by the instrumentation. You may need to use post-op MRI, or you may need to use post-op CT myelo. I personally don't have any experience about it, but results seem to go on the same lines as the de novo SBRT. So once the SBRT in this setting was found to be successful, it gave way to the concept of something called a separation surgery. So where in the separation surgery, the surgeon would first go in and do the surgery for the purpose of stabilization, and do what is the minimal necessary excision to decompress the tumor, to create a gap between the tumor. So about 3 millimeters gap is ideal, gap between the tumor and the spinal cord, so that subsequently we can move in and do SBRT to take care of the actual tumor, so that the spinal cord is not damaged. So this is the new upcoming buzz, and we hope that this would reduce the morbidity related to surgery, and will help achieving long-term local control with the use of SBRT. So the last important topic on which SBRT comes into picture is in the situation of re-irradiation, which in the spine metastasis setting is required many times, and conventional radiation had difficulty doing this, although we were doing it all the time. And a systematic review on this particular topic concluded that in about 3/4 of patients, long-term durable local control can be achieved with excellent pain relief, with acceptable around 10% risk of vertebral compression fracture, and a low risk of myelofracture. Very important, SBRT allows you to do irradiation even in those patients who have achieved, who have undergone SBRT initially. So friends, I will conclude, and I hope I have been able to convince you that radiation continues to have its role in achieving excellent pain relief and palliation, which is so important for these group of patients. But it has moved on from this role to help our other colleagues, surgical as well as medical oncology colleagues, to provide durable local control of the disease in the upfront as well as in the post-op or even in the recurrent setting. If the demand is there, if there is a need, it can help you to delay systemic therapy. And of course, it is now started contributing towards improvement in survival also. Thank you very much for your attention.
Thank you so much, Sanjeev sir, for again another lucid presentation of how much of a role radiotherapy has improved across. So what I will do right now is share my screen and share my presentation on the role of a surgeon in extremity bone metastasis. So greetings again from Manipal Hospitals and Manipal Comprehensive Cancer Center. Yeah. So again, just to push the message across and try to imply on it, it's always a team approach, and we work in a tumor board. This is our Comprehensive Cancer Center logo. That's what we are, work on. So the outline of my presentation would be, we would look at what's the approach towards the surgical management, the role of the surgeon or the role of surgical management. Are there any scoring systems which help to formulate the type of surgery intervention? Because it's really important as to do as less as possible, at the same time do what is the best possible for the patient at that point in time. Any evaluation checklist available to try to make sure we're going in the right direction, and what are the defined indications? Can I try to break it down, when to fix, curate, resect, replace, and so on, and even try to see if we can use alternative therapies or minimally invasive therapies in such situations. Lastly, if there are any future directions or controversies also. So just to start my presentation, it's always going to be a simple approach. Any sort of bone metastasis or a pathological fracture would always try to take in this sort of an approach, and we rarely do miss our way of looking at it. And yes, biopsy slide does get, try to walk into my metastasis talk also, because again, it's always important to try to get the radiologist and try to find out where we're going to get the, sample for biopsy, because time is very important in such situations of no fracture or a fracture also when you're suspecting a bone metastasis. So any patient, I would say more than 30 years of age right now with a lesion or a pathological fracture is suspected, would definitely we need to have bone metastasis as one of the first points as a differential diagnosis. So what is the role of a surgeon? Where do I come into play? Most often when there are symptoms or complications related to bone metastasis, there are a lot of diseases, primary cancers, which can be subjected to medical treatment and radiation treatment, so which are basically non-invasive, as shown by the previous two speakers. But when there's like severe pain, rest pain, pathological fractures, or sometimes when there is the nerve compression, again which should be dealt by the spinal surgeon. So these are the times when I try to come in and try to see what can I do or what can I offer. The reason being, as you can see in the right corner, osteolytic patterns are one of the most commonest presentations of bone metastasis. Whereas again, the primary tumor also often tends to be diagnosed quite later. So we try to come into play to see whether we need to fix or anything else which needs to be done in such situations. So what are the goals? Definitely we have to relieve pain. We have to find out some solution to prevent fracture if it is not yet happening. And at the same time, we have to enhance mobility and function so as to preserve the quality of life. So why surgery? Up to 30% lesions have inadequate relief with EBRT alone. That has changed a bit with SBRT, and metastatic pathological fractures, as you know, rarely unite. So we really need to see, have a clear-cut demarcation. Is there going to be instability? Has there an instability already set in? So that's when we take over from the radiation oncologist or the medical oncologist and try to see how we can help the patient out. And yes, failure of a non-surgical modality is what I put across over there. It does happen in some patients. And so what we need to look at is, do we or can we give a construct which lasts as a need of the hour? Yes, there is perioperative morbidity and mortality in such situations. The question is, do you really want to operate? That is really up to 8%. But yes, we need to do in such situations because it definitely improves the quality of life of this patient. So what is the scoring system which helps? Yes, there is one important scoring system for extremity bone metastasis called this category system, which has come into play. And this apparently, helps us try to find out how we can approach this situation. So we look at what is a primary site. Based on that, we try to see whether it's a slow growing tumor, a moderate or a rapid growing tumor. The scoring increases. Does the patient have visceral metastasis? How do you know all this? By doing a PET CT scan often, or you can even do a simple CT thorax and abdomen, where more than 70 to 80% of the primaries can be found out. We do laboratory data where we try to see whether it is abnormal or critical, and the laboratory data would be lactate dehydrogenase, CRP, serum albumin, and critical ones would be platelets, calcium, and bilirubin. We do tend to see the ECOG status, which is a performance status for such individuals, and any previous therapy or multiple skeletal metastasis. So how does this scoring actually help? So when we try to put across the prognostic scores, we say that a patient with scoring anywhere between 0 to 3 or or lesser has a longer survival time. So as the scoring goes more, the survival rate we usually say keeps on decreasing, where you would say a 7 to 10% score on a category scoring for a patient would actually mean not more than 6% survival at 12 months. So to put across plainly, a patient whose life expectancy is less than 6 weeks is unlikely to benefit from any major reconstructive surgery. So when we probably have to take a step back and try to see what non-invasive methods we can do, or what is the most minimal thing we can do for this individual to make sure that they have a better quality of life. And again, the older system which was used was Merrill scoring, but again, it's only more of the petrochantric area and some of the other limbs, but it's of limited quality, where we try to say anything less than 8 should be considered for radiation, or anything more than 8 or 9 should be considered for a prophylactic fixation because of an impending fracture. So what is the evaluation or checklist? Yes, a biopsy is must. I do it for any suspected lesion or a pathological fracture also. It would take a day or two, as we had this discussion with the first speaker. A whole body PET CT, and if it's not available, a CT thorax and abdomen would again get most of our things. Even a simple chest X-ray would pick up a majority of the primaries in such individuals. Tumor board discussion, splint supported traction until diagnosis and staging. Yes, I would definitely emphasize that final treatment can wait until a diagnosis with immunohistochemistry and prognosis is obtained. That is based on the scoring and the IHC, because that would tell me, should I be aggressive? Should I take a step back, or should I find a way in between to make sure the patient, is actually benefited and it's not about the surgery alone. And sometimes we try to do CT angiograms for expansile lytic lesions like kidney, thyroid, and lung because they're very vascular. And we actually need to evaluate the surgical approach, then the choice of fixation, what do we use to augment the fixation, and lastly, durability of the implant, because it's very important to make sure that the implant should last the life expectancy of the patient, but it doesn't, the vice versa doesn't hold good, right? So let's see certain scenarios. When to fix? Definitely diaphyseal lesions of long bones, akin to myelomas and lymphomas and other situations, metaphyseal lesions here except proximal femur, because we have seen that proximal femur lesions tend to often fail if they're not taken into account. There's been quite a bit of studies which have trying to prove that also. So what's the benefits of prophylactic stabilization? Shorter hospital stay, pain relief, faster surgery, quicker return to pre-morbid function, improved survival, and if we do curate, we need PMMA, and this is often adjuvant is added up with radiation or target therapy or chemotherapy. So when to curate and fix? Yes, definitely when there's a soft tissue mass. So this is another criteria for me as to where I would curate it. We should be very careful in certain areas like kidney, thyroid, and lung, where they're going to be highly vascular. So we need to make sure that whether we use a tourniquet or do an embolization also. Stabilization does help, and what it achieves is that it allows immediate mobilization. We as surgeons are more confident to say, yes, please go on, weight bear and walk, or weight bear, do your activities over there. And we try to use liquid nitrogen or cement in such situations to augment the construct. And never ever use a bone graft. Similar situations, renal cell carcinoma, a small depressed fracture, multiple other lesions, so went in, curated, cemented, and fixed it, so the patient is able to walk the next day full weight bearing. Again, another renal cell carcinoma, curated and fixed with a plate, and again CS stomach patient with multiple metastasis, curated and fixed with a plate, and all these patients often either get radiation or targeted therapy or immunotherapy, whichever it is. And this management of skeletal metastasis surgeon's guide is one of the really good guides as to how we can look across treating these patients. Again, when to resect? Definitely, just like how SBRT has come into play, when we are faced with solitary or oligometastatic disease, we are actually looking at prolonging the life of a stage 4 disease patient. So kidney, thyroid, breast, and even rectum and lung nowadays have a role of doing resection in such cases. And I would also add that pertrochanteric solitary bone metastasis of any origin, or where the morbidity is going to be too high, can also be taken in for resection. Pathological fractures, which are juxtaarticular or pertrochanteric area, again can be taken in. And often these ileum, ramus, and ischium metastases tend to be very painful. They may also benefit from resection alone in such situations. So similar, yeah, we can see here that there's a big pelvis mass, RCC, and there is enough studies to say that it actually improves the survival, and the palliation also, is better. So better results are seen with a prolonged disease-free interval. Situation where the same patient had pazopanib, denosumab, then angioembolization, then actually patient underwent internal hemiplectomy, and for technical reasons we actually could not put in a 3D printed prosthesis, because we felt that he had other comorbid issues. So we did the resection and a pseudoarthrosis, and you can see that the patient is able to weight bear and walk with the help of 2 crutches, and later with a single crutch. So yes, the quality of life is going to be a bit better off, and such extensive surgeries do sometimes have a role in solitary or oligometastatic diseases. Again, similarly, segmental bone loss, proximal femur lesions can also be taken care of. Some situation where we've tried to implant intercalary disease in the tibial metastasis. Similar situations where pathological fractures, evaluated, resected, tumor processes put. Again, distal femur pathological fractures in breast adenocarcinoma, solitary metastasis, resected, tumor process put. So these patients tend to have a better quality of life, and it also helps us that the disease burden is taken away, and patient can actually have a longer life with a curative intent. Again, other situations where we often try to say it's better off to resect rather than fix is a very good example of carcinoma thyroid being fixed. Then patient unfortunately did not take adjuvant therapy, missed out on it for many reasons. And then patient came with a huge mass in the proximal femur with a disappearing bone, and the patient underwent embolization, then resection, and a tumor process. So patient was walking basically from the next day onwards. Yes, maybe we could have avoided this. Maybe patient was, did not wish to take adjuvant therapy, but whichever it is, unfortunately ended up in problems. But we also had treatment option available with us so as to make sure that their quality of life is better. Again, another silly situation, nailed fracture of the carcinoma thyroid, then the whole thing broke because of some maneuvers and the patient had to undergo surgery again, where we had to resect it and fix it because there was no other disease focus anywhere else in the body. So what's the evidence when you look at, as a surgeon, I'm trying to put across replacement after resection, impending or, pathological fractures, we say that IL nailing is pretty less expensive, but it does not help the fracture to heal. Yes, even with RT, 30% or less can actually heal, especially when there is a soft tissue mass, and prolonged bed rest can be there even in a radiation setting also. But at the same time, endoprosthetic reconstructions are definitely gaining acceptance, and it's justified even in reduced survival because there's a hope of improved mobility, which you can see by the articles which put across. So yes, we try to see if we can improve the survival and we can improve the mobility also, even with a little bit accepted, increase in the mobility. Role of embolization, yes, definitely they have a lot more role to play when we anticipate hemorrhage with neurovascularization or when we're trying to curate a resection. So the role of interventional radiologist definitely has changed the way we treat these situations. So what are the pitfalls of surgical management? Not everything is rosy. So the overall operation rate has been reported between 3 to 15%. So we really need to think a lot, take a step back, think whether we're doing the right thing or not. And median time to revision or reoperation, they say, has been up to nearly 17 months. So patients with metastatic bone disease from breast, RCC had the longest survival rate, whereas presence of, as put across with category storing, multiple metastasis, multiple path fractures, the type of primary is aggressive or presence of visceral metastasis has often shown us that, they are poor prognosticators, and we need to relook and rethink what sort of a surgery we can offer. So again, surgery at one type is not the mantra for all these patients. So we really have to, take in a lot of, points to make sure that we give the best option. So just to summarize the surgical role, clavicles and, ischiums do not need any surgeries. Proximal humerus, again, we can go with curettage or any replacements. Diaphysis of the humerus of the long bones can always take in nails or plates and with cements, plus or minus curetages. Proximal femur, definitely, yes, there's a role for endoprosthetic versus fixations. And if you see periostelar lesions, minimal invasive is also a way, and we can even try to take Harrington's type of defect management, and we can go all the way up to pseudoarthrosis or even, 3D printed processes or custom pelvic processes also, if we feel that the patient is going to really have a long life in such situations. Around the knee, again, we have to treat it as a juxtaarticular situation. And tibia, yes, below the knee, often they say it's rare, but still we can go for a segmental if it's oligometastatic, or IM nails with or without cement and curettage if we feel it is a multiple metastatic situation. So when to go minimally invasive? Yes, there is a role in in axial disease more than appendicular disease. Percutaneous cementoplasty is one where the spine surgeons would be more, happy to share their views across. And also acetabulum, there's a lot of, advances where we're trying to do cementoplasty in periacetabular disease also. This can also be followed up with radiofrequency ablation, cryotherapy, microwave, or even high intensity focus ultrasound if there's an opportunity of that available in the setting. So when we try to say we'll take a step back, can we be not aggressive also? Yes. More than 7 category scoring, unknown primary, which occurs in nearly 10% of the situations, multiple lesions, and painful mets of the ischium, pubis, ilium, and SI joint sometimes may benefit from RT also. Again, resection versus RT will have to take it in there. So how do we do it and how do we treat these patients? Bracing, radiotherapy, bisphosphonates, and supporting care is again the way ahead. So coming to additional therapies, I said, denosumab also has helped a lot, where we have a patient who apparently had a malignancy of unknown origin with multiple lesions. Just before surgical plan for stabilization of the periacetabular disease, patient had deep vein thrombosis and was just short of pulmonary embolism, and then we had to take in the help of denosumab, where patient who was bedridden could actually, after 4 doses, was able to walk with aid of a crutch. There is a protrusion available, seen over there. There is some bit of a deficient medial wall, but at least the patient from bed has got up and is able to take care of at least of the basic needs. And we're looking at trying to see we can have this as a continuation mechanism and see how the patient will improve. So future directions and controversies, we have to more improvise on the criteria for impending fractures, see the role of RFAs, cryotherapy. Acetabular has a role. Again, less centers do this. So we need to see whether we can, try to do a minimal invasive clearance and try to do a scapuloplasty. Denosumab, yes, it has a very big role in metastatic bone disease. Systemically, they do give it, but locally also we're seeing a lot of changes in certain situations, whereas it will be a conservative way or a surgical way. And angiogenesis inhibitors are again also going to take it a lot more forward. So these are, the recommended readings as to how we can try to improvise our management in metastatic bone disease, in extremity bone diseases. Thank you so much. So I'd like to request Dr. Thomas Kishan to share his presentation on spinal metastatic management, the surgical part of it, which is the biggest bulk of the metastatic bone disease.
Good evening. At the onset, I'd like to thank Dr. Srimant and the team from the Comprehensive Cancer Care Center for this opportunity to speak at this webinar. The topic that I'm going to cover today is metastasis in the spine. So we know that 2/3 of cancer patients develop bone metastasis, and the most common sites, primary sites, are the breast, prostate, and the lung. So spine is the most common site of bone metastasis, and the spread could either be through the venous system, the arterial lymphatic system, or by contiguity. The most common primary sites being the breast, lung, prostate, the kidney, the GI, and the thyroid. So the breast, lung, and prostate being the more common ones. And the thoracic spine is the one that is involved in a majority of the times. And it's mainly an extradural lesion that you have, and very rarely do you have intradural mets. So what the metastasis can do is it can cause, involve the vertebral body, causing a collapse of the vertebral body and pain. It can cause an epidural component of the metastasis, can cause cord compression, and can also be a leptomeningeal tumor deposit. This can present with back pain, may be radiating to either to the chest in the girdle distribution. If there is compression on the spinal cord, the patients can have difficulty with walking, with loss of sensation and muscle weakness, either in the upper limbs or lower limbs or both. There may be a loss of bowel and bladder function as a result of neural compression. Rarely there may be spinal deformity due to destruction of the vertebral bodies and paralysis of various degrees. So evaluation of a patient with a known primary, I mean, we've gone through this already, so I'm going to skip this. So my role as a spine surgeon is, I'm very clear of my role as a spine surgeon. So since metastasis forms a small part of my work, I depend a lot on inputs from my colleagues in medical and radiation oncology and I discuss a lot with them before I actually take any patients up for any procedure. So we look at what is the prognosis, what are the benefits of surgery, can it be treated in some other way with either radiation or chemo. So those are the things that we discuss before we actually take the patient up for spinal surgery. So before we think of surgery, and if the patient does not have a known primary, a biopsy is very useful. And this is more so if the patient does not have a neurological deficit. But some patients come in with significant neurological deficits or sudden onset paraplegia, and those patients, we take them up for surgery straight away without a pre-surgical biopsy, and we use the bone obtained during surgery to get a histopathological diagnosis. So a biopsy, if there is no neurological deficit, a biopsy is mandatory. It helps in planning. It helps in planning the surgery. It helps us to discuss with colleagues in medical and radiation oncology as the best way forward for this patient. So biopsy in the spine, I prefer to do it myself. We do it fluoroscopy guided and using a Jamshedi needle. That's how it's done. It can be done either under local, it can be done under general anesthesia, it can be done under sedation. It all depends on the patient's comfort. So pretty straightforward procedure. The aim is to get some adequate cores which can be sent for histopathology. So once you've come to a diagnosis of a spinal metastasis, and we know what the primary is, it's important to predict the prognosis. So there are numerous scoring systems. The modified Takahashi scoring system is popular. A score of 0 to 8 on the Takahashi scoring indicates that the survival is less than 6 months. 9 to 12 score indicates more than 6 months survival, and 12 to 15 indicates a survival of more than 1 year. And that tells you how aggressively you can treat the patient. So they look at the scoring looks at general condition, number of extraspinal bone metastasis, number of mets in the vertebral body, mets in other major organs, primary site of the cancer, and whether the neurological status of the patient. So there is also the norms scoring, which was alluded to earlier. So when we look at the neurological status, the oncological status, whether it's radio resistant or not, mechanical instability is very important in the spine. Is there a burst or compression fracture? Is there an impending deformity? Is there an impending neurological deficit, and the systemic disease? So the other one is the spinal instability neoplastic score, which which scores patients based on the location of the tumor, whether it's in the rigid part of the spine or in the junction between the cervicothoracic junction or lumbosacral or a thoracicolumbar junction, whether it's a mixed or a blastic lesion, whether there's a deformity, whether there's a collapse, pain, and what the posterior elements look like. So the aim of surgical intervention in the spine can broadly be divided into three. One is to reduce pain. One is to prevent or reverse neurological compression or deficits. And very rarely do you have a curative intent, because we're looking at predominantly palliative, surgical wise, not the overall treatment. So if the patient has instability pain, then surgery is a good option. If they have just tumor pain in the spine, then they're referred to the radiation oncology department, and they do well with radiation to reduce the pain. But if the pain is instability related or fracture related, then they may do well with stabilization of the fracture. If the patient has a neurological deficit, then I think there is a good reason to do surgery, because if the patient has to have other forms of adjuvant treatment like radiation and chemo, it's probably better to do it once the spinal cord has been decompressed. So the surgical options can be broadly divided into three. Either you do a vertebroplasty, which is less common, an en bloc spondylectomy, which is also less common in metastasis. The most common one is probably a decompression and stabilization procedure. So the vertebroplasty is percutaneous injection of bone cement into painful pathological fractures. These are predominantly done when the patient is not able to tolerate any other surgical procedure. But now with the advent of minimally invasive pedicle screw insertion, most of them can be treated with spinal stabilization, which gives more predictable results rather than pushing bone cement into a tumor. This is what it looks like, multiple fractures, which, in a patient who cannot be treated with any other form of treatment, who suffers with a lot of pain. Some of them do improve with vertebroplasty. The other thing that needs to be talked about is the role of preoperative embolization. If you think that the metastasis is likely to bleed a lot, then there is a good reason to do a preoperative embolization, and this can significantly reduce the bleeding during surgery. So give you a couple of examples. This is a 50-year-old lady with a single spine met from the primary from a clear cell renal cell carcinoma. So since there was a single met, in discussion with the oncology team, with the medical oncology team, we decided that we'll take the whole vertebral body out. So we did what is called an en bloc spondylectomy, remove the whole vertebral body as well as the posterior elements, replace it with a cage, and stabilized it from the back with screws and rods. And then the patient went ahead with adjuvant therapies in the form of chemo in this patient. This is one. So this is en bloc spondylectomy. This is another patient who presented with sudden onset paraplegia, and there was on the X-ray, there was something, one of the pedicles appeared to be missing on the X-ray, and this is, the classical winking owl sign. And there was some irregularity of the end plates there. CT scan clearly showed that half the vertebra was actually replaced by tumor, and it was extending into the spinal canal. And the MRI showed significant cord compression. So this patient underwent an urgent decompression and stabilization surgery. So we did a partial corpectomy, removed a part of the tumor, pressing on the spinal cord and stabilized it above 2 levels above and below with that, and then replaced it with used a cage for providing additional stability there. So the patient recovered neurologically and then went on to have other forms of treatment to treat the primary cancer. So this is another patient who actually Dr. Amit's patient. So 66-year-old gentleman who presented with carcinoma of the lung with spinal mets. So we saw him, I think, in 2017. And at that time, that was the X-ray on the left was what it looked like initially. At that time, we decided, I decided that I'd probably not operate on him because he was still ambulant, bit of weakness in the hands, but still ambulant, but his lung cancer looked very advanced. So we let him be. We thought we'll just treat him with palliative chemo, but then he went away somewhere, came back, and then Dr. Amit put him on some immunotherapy and then referred him back to me after a year saying that you should probably operate on him now because his disease has been controlled. So by this time, he had become completely non-ambulant. He was on a wheelchair and he had lost function of both hands. So we went in and did a very extensive surgery from the front and the back. So did a partial corpectomy, reduced the compression from the front, went in from the back and stabilized it at multiple levels along with the laminectomy. And then a couple of months later, we found significant improvement in his neurology. His hand function improved to near normal. He's walking around now. And I think he's 2 or 3 years post-surgery and doing very well. But not all tumors, all lesions that you see in the spine are Mets. So this was a 55-year-old gentleman who presented with sudden onset weakness in both lower limbs and difficulty in walking. We saw a lesion like that. You can see the cord compression there. And you can see that, the cord is encircled by this lesion. We thought it was a Met. So we went in urgently, did a wide decompression and stabilization like this, sent the specimen off for histopathology, and it came back as a Brown's tumor, secondary hyperparathyroidism because he was on renal dialysis due to renal failure. So not all lesions are Mets, but Mets are most common. And the role of spinal surgery is, is always in collaboration with the doctors in the medical oncology, radiation oncology teams so that the patient gets the best outcomes. Thank you.
Thank you, Dr. Thomas. Mr. Amit, any questions from any of the participants? Have you received any questions, please?
In chat box, nothing, sir.
In chat box, nothing.
They can unmute.
Okay.
They can
I guess we should be able to end the session. Dr. Thomas, I think we can end the session, right?
Yeah, thank you.
Yeah, thank you so much, sir.
Thank you.
Basically, my thanks to Manipal Hospital, Manipal Comprehensive Cancer Center, and also many thanks to Dr. Neeraj and team from OrthoTV to help us reach out to more doctors and participants interested in treating metastatic bone disease. So we'll be seeing you on the 23rd of December with the soft tissue sarcoma session. So until then, a very good night and thank you for attending. So Dr. Neeraj will be ending the session now. Dr. Neeraj? Yeah.
Doctor is not in the screen. He'll just...
Not an issue. So we'll be stopping the session. Please, you can end the meeting, Amit. Thank you so much. Thank you, everyone, for attending. If anything is there, you can just reach out to us on the mail or through Amit, and we'll be more than happy to revert you. Thank you.
Thank you, Doctor.